everyone for joining us today. We'll get started in just a minute. We have a good number of folks jumping on, so I think we can go ahead and get started. So on behalf of the American Heart Association, I'd like to welcome you to today's event, Emerging Device Therapies to Treat Patients with Progressive Heart Failure, Adoption and Implementation Strategies. This event is made possible through the AHA's Heart Failure Education Initiative, which is a 3-year initiative supported by Abbott that's focused on the rising need for advanced treatment pathways and education beyond guideline-directed medical therapy. We're providing a number of education events throughout the duration of this initiative, and I'd encourage you to visit the website at the QR code to learn more. As part of this initiative and in support of Heart Month, we are also excited to be hosting 3 additional events as part of this Lunch and Learn series each Thursday in the month of February. I welcome you to scan the QR code on the screen to register for these upcoming events, or you can access the registration flyer in the Resources tab. Before we begin, I'd like to quickly review how to use today's platform. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that doesn't work, please review the system requirements or contact the Zoom webinar helpline. To access live closed captions, please click on the closed caption button found on your screen. Throughout today's presentation, you'll have the opportunity to submit text questions using the Q&A feature on your control panel. You may send in your questions at any time and we'll review them if we have time at the end as it allows. PDFs of the presentations are also available in the Resources tab. Finally, this event will be recorded and available within the coming weeks throughout the Zoom webinars and on our Heart Failure Education website. Before we begin, I'd also like to take a moment to remind you that the opinions and recommendations presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by AHA-ASA. The AHA-ASA does not endorse any product or device. And with that, I will turn it over to today's presenters, Dr. Timothy Fendler and Lisa Jennings from St. Luke's Mid-America Heart Institute in Kansas City.
Thank you, Kelsey, and thanks to the AHA for this opportunity. We're excited to talk about novel device therapies and their growing space in the treatment of patients with heart failure. Next slide, please. These are my disclosures. Next slide. So when we think about treating patients with heart failure with reduced ejection fraction, I sort of think of them as fitting into 3 buckets. When we use the standard guideline recommendation treatments for patients who develop heart failure with reduced ejection fraction, there are obviously 3 scenarios. One is that they get better, one is that they get worse, and one is that they live with what we think of as chronic ambulatory heart failure symptoms that may not shorten lifespan, but can definitely reduce quality of life. Next slide, please. And so when we think about how we adjust to each of these 3 different buckets of patients who get better are followed regularly in our clinics. Patients who get worse, if they get worse enough, end up being hopefully moved on to a center that can do advanced therapies evaluation. Think about things like transplant and LVAD. And then probably the large bulk of these patients end up with chronic ambulatory heart failure. And this is where I think of us as having to go back to the drawing board. Next slide, please. So what does that drawing board look like? Well, that drawing board has gotten larger and larger in the last 2 decades. We know that guideline-directed pharmacotherapy for heart failure with reduced ejection fraction has grown in a number of ways, a lot of medicines that improve quality of life and reduce hospitalizations, if not improve mortality. We know that there are now a number of valvular interventions. We know that there's a lot of stuff within the world of electrophysiology that we can utilize for these patients, including but not limited to CRT. And then obviously there are a lot of specialty referral opportunities for patients who fall into different niches of heart failure with reduced ejection fraction based on the etiology. But probably another large space, if you could just advance, please, that is really seen a lot of growth, especially in the last decade, are novel device therapies for heart failure. I'm going to quickly go through three of these and the evidence behind them. And then what Lisa and I are going to spend the bulk of our time doing is talking about how we've worked to build programs around these device therapies at our Advanced Heart Failure Center. So the first is probably the one people are most familiar with, implantable pulmonary artery pressure monitoring systems. There are now two on the market. You see here a picture of the first and its size and location where it's placed in either the right or the left pulmonary artery. The science behind these is based on the fact that we understand that patients develop elevations in pulmonary artery pressures as a result of fluid accumulation probably a week and a half to 2 weeks before they develop clinical manifestations of symptomatic heart failure. Go ahead and advance. Based on that knowledge, companies have created these devices that are able to keep monitoring of pulmonary artery pressures and identify for a treatment team when those pressures start to rise, again, hopefully in advance of symptoms occurring. And in randomized trials, the results of one of which are seen here, these devices have been shown to reduce the risk of heart failure hospitalization and to improve other important metrics for patients like quality of life and functional status. You can see on the bottom right of this screen now, an example of a pillow that a patient lays on to transmit pressures from the device inside the pulmonary artery to the pillow, which then sends the readings to the electronic health record where the team can get readouts like you see at the bottom there, and can use those to guide treatment decisions like changing diuretics or guideline-directed medical therapy. Next slide, please. What I tell patients about these devices are that they're like the lights that go on in your car that remind you that you're getting close to running out of gas or that you need an oil change. And what I tell referring clinicians when we think about putting in these patients who get referred to us for consideration of more therapy is that if you're going to find out that your plane has a malfunction as a pilot, you'd rather do it when you're way high in the air and you have time to problem solve than when the plane is about to land and you suddenly realize your landing wheels aren't going to come down. So this is really an advanced detection system, essentially. Last year was a big year for these devices because they received what's called a national coverage determination by CMS that has led to a significant increase in insurance coverage from a number of Medicare Advantage and private insurance plans. And that's really been one of the bottlenecks to getting these devices implanted, is getting them covered by insurance. So that was a really nice leap forward for availability of this diagnostic tool. Next slide, please. Our experience here at St. Luke's, our program started in 2017, and it's grown steadily with each passing year. In 2025, we passed 100 devices in a year between the two devices that are now on the market. We have a nurse-led program for identifying, educating, and then managing these patients with advanced practice provider and MD or DO oversight. And we've seen anecdotally significant reductions in our heart failure readmissions, urgent clinic visits, and requirements for IV Lasix. When we've looked at our own data, we presented an abstract a couple of years ago at HFSA that I'll show if I have time today. And we've definitely seen different patient trajectories that emerge when using these devices to try and optimize care. We've seen that patients who are non-adherent obviously don't download and don't get much benefit. We've seen patients who comply with downloads until they get better and oftentimes can download less often. We've seen patients who are compliant with downloads and they have a waxing and waning status, not a surprise in the world of heart failure. And then we see those patients who are compliant and still struggle. We have trouble getting their pulmonary pressures down. And we've seen a lot of emerging evidence in the last 5 years that that's associated with significantly worse prognosis and may lead us to think more about things like LVAD or transplant when applicable. Next slide, please. The second device I want to talk about, a little bit newer, a little bit less evidence, is cardiac contractility modulation. As you can see in the picture, these devices look and are placed just like a traditional pacemaker with two wires that end up in the interventricular septum sitting in the RV. They're implanted by electrophysiology cardiologists. CCM, which we call it for short, delivers precisely timed energy pulses to the heart in a non-excitatory fashion during the absolute refractory period, so they don't cause arrhythmias. What CCM does do is it optimizes and improves intracellular calcium cycling and homeostasis. We've also seen that it increases titin phosphorylation and upregulates a number of cardioprotective genes. So very positive gene expression profiling for chronic heart failure patients. This leads to, on the pathophysiological level, improvements in both contractility or inotropy, and we also have seen in basic science studies improved lusitropy or relaxation during diastole. And the effect on the heart and the patient is pronounced, which you can see on the next slide, where we look at some of the study results for this device. There have been a number of studies. The very first study of this device, which was with a previous iteration before some of the technology was improved to decrease risk of complications from the device itself, was a double-blind, double crossover study where patients acted as their own control. So the device was placed and then was either on or off, and patients didn't know whether it was on or off. And in that initial study, there was a noted increase in peak VO2 that was statistically significant. This led to a number of randomized, non-blinded studies in which patients with the device were compared to patients with optimal medical therapy. And in those studies, again, we saw over and over improvements in peak VO2, as well as improvements in other important outcomes like patient-reported outcome validated studies showing quality of life improved. We've also seen improvements in things like NYHA class as assigned by physicians or providers, and improvements in patients' overall symptom burden and functional status through things like the 6-minute walk. In more recent registry data, we've even seen signs that there may be improvements in or reductions in heart failure hospitalizations, and perhaps with time we're going to find that there are even greater benefits with this therapy in place. Next slide, please. This is a nice graphic that came from a review of CCM about 5 years ago, using the speedometer metaphor to explain where these devices fit in the modern landscape of heart failure care. CCM is indicated for patients with ejection fraction between 25 and 45% currently with NYHA class 3 or 4 heart failure symptoms who are either not candidates for CRT or who are non-responders to CRT. And in those patients, that's the patient population in which this device has been approved, FDA approved. There are potential expansion points for this device in the future. There's an ongoing trial right now looking at the use of the device in patients with EF between 40 and 70%, so heart failure with mid-range and preserved ejection fraction. And there is a trial that came out earlier in 2025 that showed that a combined ICD and CCM device was non-inferior to traditional ICDs. That device, Integra D, should be on the market sometime, probably in early 2027, from what I've heard, but should be a real game changer for anyone who warrants consideration for primary or secondary prevention ICD in the setting of a reduced EF. You can see here how I describe this to patients and how I describe it to referring clinicians who are unfamiliar with it. This is a nice adjunctive therapy that acts directly on the myocardium. Clinically, we've seen it work especially well, in my opinion, with patients with non-ischemic cardiomyopathies, oftentimes genetic or familial cardiomyopathies. Next slide, please. So our experience here, we started implanting just a few years ago, and we've implanted 36 so far, most commercially, some through that trial of the combined CCM ICD device, and some through the trial I mentioned for patients with mid-range and preserved ejection fraction. Anecdotally, we've seen significant improvements in quality of life as per the Kansas City Cardiomyopathy Questionnaire score. We're also seeing a small increase on average of 3 to 5% in ejection fraction in the 3 to 6 months after the device is implanted. That's also a finding that's been seen in some of the registry data in the last few years that's now available for review. And we've not really seen any major challenges as far as complications, no significant increase in TR, even in patients who already have a pacemaker or ICD and get a second device, a CCM device. I will say, however, that when we think about advanced therapies options like transplant or LVAD, I think of the venous pathways as being real estate of a type. And so if we're filling it up with wires, it's probably something that may create challenges or special considerations for patients who may need advanced therapies later on. Go ahead and skip ahead. CCM, just like pulmonary artery pressure sensors, received a national coverage determination from CMS in the latter part of 2025 in October. And even after that time, we saw a significant uptake in insurance programs like Medicare Advantage and private insurers approving implant. So that's obviously going to be something that helps to grow our program and programs around the country even more for this really exciting new device. Next slide. The last device I wanted to talk about was baroreflex activation therapy. This is a device that's based on this concept of baroreceptors that are inside our vascular walls. They're there as homeostatic mechanisms. They sense changes in blood pressure and send messages to the brain that causes it to alter levels of parasympathetic versus sympathetic nervous activity to either decrease or increase cardiac output and vasodilate or vasoconstrict. Next slide, please. Baroreflex activation therapy, which we call BAT for short, is a small device you can see in the picture there, implanted usually by vascular surgeons or cardiothoracic surgeons. It is extravascular. The wires are below the skin, and with a small cut down, the small sensor is directly attached to the carotid baroreceptor in the carotid sinus. The device is turned on and then turned up over the course of a few visits, and sort of tricks the brain into increasing vagal output, parasympathetic nervous system stimulation, and decreasing sympathetic stimulation. So you can think of this as combating the sort of the chronic adrenaline fight or flight response that our patients with chronic heart failure with reduced ejection fraction always live in. And in a major landmark trial published in 2020, that was shown to improve exercise capacity, to improve quality of life, and even to reduce biomarkers like NT-proBNP. Next slide, please. So on one hand, this new therapy is really exciting. We've got one high-quality, multi-center, non-blinded, randomized controlled trial where BAT was compared to optimal medical therapy and showed significant benefits, including reduction in biomarkers, which is, a little more objective than something like quality of life scores. The device is extravascular, so no venous real estate is lost, like I mentioned with the prior device. It's overall a low-risk endeavor once the device is in. The company's motto, who makes the device, is set it and forget it, because once it's on and doing what it does, it will do that for the remainder of the patient's life. That's kind of true of CCM as well, although CCM does require weekly charging sessions with a small charger while the patient is sitting. This doesn't require that, just battery changes every number of years. And it obviously combats that chronic fight or flight response that patients with heart failure are dealing with. So that's on one hand the good things. On the other hand, if you advance for me, the challenges we see are that it's a surgical implant. We're working with a new area in heart failure. The heart failure umbrella is getting bigger and bigger, and we're collaborating with a lot of different specialists. But for our center, at least, vascular surgery is a new relationship. Insurance coverage has definitely been a barrier to programmatic growth. This is a device, if you're familiar with codes, that just had a T code until January 1st of 2026. There's now a Category 1 code, so we're hoping that we will get better luck with getting these devices approved for implant. There's no evidence yet of what we think of traditionally as hard endpoints like mortality or rehospitalization, although I would argue that quality of life benefits are significant and important to patients. And with only one study, the size of benefit remains, I think, still uncertain whether or not what we're seeing is a placebo effect, although reductions in cardiac biomarkers is a nice objective data point, in my opinion. This is what the device looks like and where it is implanted. And if you just advance again, the way I talk to patients about this device are that it sort of stimulates the brain to tell the heart and blood vessels to relax, that allows the heart to work more effectively despite it being in its weakened state. And what I've told my clinicians that refer patients to us that we put this in is that we can now use neuromodulatory pathways to improve the heart failure patient, not just with medicines, which can sometimes be limited by hypertension, but now with new device therapy. Go ahead to the next slide for me, please. So our experience here, we just started implanting these about a year ago. We referred 10 patients in most of 2025, and we're only able to get 3 implanted. Lots of insurance denials. Again, that Category 1 code we hope will be a game changer in 2026. As far as the experience with R3, the device gets turned up about monthly for 2 to 3 months. And we had 2 patients who felt poorly when the device was turned up maybe a little too high. But after it was recalibrated, they did fine. And all 3 have have reported significant improvements in their overall quality of life and ability to do things without getting winded. There is another upcoming multi-center randomized trial that we're going to be participating in. We're excited about that will hopefully show similar benefits and will expand the indication. Right now, this device is approved for patients with ejection fraction less than 35%, with NYHA class 3 heart failure, and with elevated NT-proBNP. They used a cutoff of 1600 for NT-proBNP in the trial, and so that's what the official FDA labeling is for. We do find that insurance, Medicare will cover it even if the NT-proBNP is higher. There are some data points that may say that when the NT-proBNP is significantly elevated, reliably above 5,000, the benefit is more in question. So I would say we're still learning about this, but it's another exciting tool in our armamentarium. Go ahead and advance. So I just call your attention to this and then I'll move on, but this is a great review that was in the Journal of Cardiac Failure from HFSA at all of the device therapies that are now available for heart failure with reduced ejection fraction patients, LVAD, valvular interventions, and the 3 devices that I just mentioned. So I would take a look at that if you're more interested. It's a really nice comprehensive piece. Go ahead, next slide. I'm going to segue now to talking a little bit about how we identify these patients before Lisa gets into how we manage them and the nuts and bolts of these programs. So I mentioned that sometimes people get sent to us for advanced therapies evaluation for transplant and LVAD, and sometimes they're too well for those options, but they still have this problem of living with chronic symptoms that affect their quality of life. And all of these devices are wonderful devices to think of when we're then communicating back to referring providers. CCM and BAT are things we can implant and titrate and then send the patient back completely to their providers. Really doesn't require any maintenance or upkeep. And like I said, set it and forget it. Once these are on, they do what they do, and hopefully those will be good things, but there's not a lot of maintenance required. Even pulmonary artery pressure monitors allow for remote care of patients that are far from you. And sometimes we do collaborative agreements with referring providers where we place these if they don't have a program yet, where we still help to manage, or sometimes we just make those pressures available to referring providers, even though we're the implanting center. So there are a lot of ways to do good collaborative care, but there are other ways that we've started to find to identify patients and match them to these really great therapies to improve their overall trajectories and quality of life. And I'm going to talk about those now. Next slide, please. Probably the first and most impactful thing that we've done is, we acknowledge that the heart failure epidemic is a massive one. And as heart failure providers and general cardiology providers, we all know that our time's limited. It's divided among a number of different requirements and needs within our different practices. And ultimately, our time is inadequate. So we, with some industry support years ago, did an implementation science study where we designed and implemented a workflow at our hub hospital in our hub and spoke model to circumvent a lot of the common barriers to implantation of pulmonary artery pressure monitors. This study was approved just after COVID, so you can kind of get a sense of our timing back then when we were still struggling with insurance coverage for PA pressure monitors. So what we did is we identified at-risk patients during primary heart failure admissions, and we trained and utilized cardiac nurses to guide and direct their care with MD oversight. In this pilot, we leveraged virtual visits and electronic health record communication technologies so that nurses could educate patients who'd been admitted for heart failure in the week or so after their discharge. And we looked at how well we could get these devices into people who would benefit from them, and compared that to usual care by tracking how our patients did at our 3 spoke hospitals during the same time period. Next slide, please. In that study, which ran for mostly the second half of 2022, we screened just under 500 patients at our hub hospital, and there were 22 that met our pretty strict inclusion criteria and were approached by our cardiac nurses. 8 of those agreed to participate in a virtual video visit and did so within 7 to 10 days after discharge, when they were back in the comfort of their home and out of the stress of their admission. And what we saw at the time is these were symptomatic patients even after their heart failure admission, with a KCCQ overall summary score of 62.5, which is usually consistent with NYHA class 2 to 3 heart failure in the literature. We surveyed these patients after their nurse-led education session, and these patients reported a high amount of satisfaction with a nurse-led shared decision-making process. They did not miss doctors or nurse practitioners in this environment, and patients reported no decisional conflict when opting whether or not to move ahead with PA pressure monitor implant. We ended up implanting 6 of those 8 patients, and we did so within about 2 months as far as median days to implant. When we compared that to a similar size and level of sickness population of patients who were admitted with heart failure admissions at our 3 spoke hospitals, from that population, only 2 were implanted within 90 days of that admission. Next slide, please. You can see here the workflow, cardiac nurses trained on pulmonary pressure monitors so that they could become experts in talking about them and answering questions, screening and approaching patients in the hospital, engaging in a post-discharge virtual visit via our EHR, and if patients consented to implant, the device was ordered by nurses under one of the physician oversight's names. Next slide, please. As I mentioned, we saw a great result from this implementation of this workflow pathway. During the 6-month period, I mentioned that we implanted 6 patients from that implementation workflow pathway, and we implanted 16 patients during the same period through standard pathways. And most of those 16 patients were from our hub hospital system, but had not met the strict inclusion criteria we used for this pilot. When we compared, like I said, implants from that 6-month period from our hub hospital to the control group in our 3 spoke hospitals, we had a 6 versus 2, so a 3 times increase in how many we were able to implant. And the patients really responded well to a nurse-led intervention, had no decisional conflict on choosing whether or not they wanted the implant, and reported high satisfaction scores with their nurse-led intervention. Next slide, please. What was really great about this small pilot is that we were able to turn this into real clinical practice. So what you see here is an electronic health record message that our PA pressure monitoring nurse team, who do screening, education, and management of our PA pressure monitored patients, they comb our census of our 4 hospitals at all times, and they send us these in the small white box, a little blurb to a number of heart failure providers showing us a number of pertinent details about patients who've been admitted for heart failure. And then as a group, 4 or 5 of us review those when we have time, and we make recommendations either to order an implant for one of these devices, or to, we'll reach out to one of our partners who's going to be seeing the patient within a week or 2 and ask them if they'll talk to them about it. If we decide to move ahead with implant, our nurses call and do education, and then the device is ordered under one of our names. And we saw nice steady growth in how many of these we were implanting in the 2 years after the pilot was completed. So this has been a huge workflow pathway for us to identify patients. And not only for this device, we've turned this workflow pathway into kind of a workaround for all of the different areas of heart failure. So we're using this to identify patients for CCM, for BAT, to refer to our structural valve team for valve interventions, to think about advanced therapies evaluations like transplant and LVAD. This really is a pretty boundless workflow pathway. And once you have something like a PA pressure monitoring program in place with nurse power that can do this screening and education, it really takes a lot of the work out of our hands. It also allows us to get our fingers on a lot more patients. I think we all know that there's limitations in how much we can do when we're managing patients who are being considered for transplant and LVAD and doing their chronic management afterward in advanced heart failure centers like ours. And this allows me to touch so many more patients that I'm not ever going to see in clinic to match them to devices that can be helpful. Next slide, please. The last thing I want to mention briefly is our combined EP and heart failure clinic. I think in the modern era of healthcare, subspecialization has led to a lot of siloing, and we're guilty of that in cardiology as well. Next slide, please. When we think about the worlds of EP and heart failure, there's actually a lot of overlap in the Venn diagram that exists. Go ahead and advance. And again, one more for me, thank you. You can just go till you see 4 things there. So in that Venn diagram, there's a lot of overlap and a lot of work we can do together. And not only device therapy, like what this talk is about, but arrhythmias, atrial and ventricular, and obviously bundle branch block patients. Next slide, please. So we created a clinic such as this, and we based this on the work of Aaron Gordeski, who published his work on CRT non-responder clinic workflow just about 7 or 8 years ago. This was a concept based on the idea that placing a CRT is oftentimes when we pat ourselves on the back and say we've done the right thing, but that's really not the end of the story. It's just the beginning, because some patients don't respond. And so Dr. Gordeski created this workflow and published about it, and we took this model and ran with it. Next slide, please. This clinic has been a really amazing clinic for us. There are 2 of us advanced heart failure specialists and 2 of our EP colleagues who staff this. We do a half-day clinic about 2 times a month. They're 40-minute appointment slots, which is nice, a lot of time. Before the visit, the patients complete a 6-minute walk and a KCCQ quality of life survey. And then we together review the patient's case and discuss before going into the room. In the room, oftentimes the heart failure provider does the history and exam, while the EP provider with a device programmer looks through the patient's CRT device or pacemaker. And then we come together at the end. We talk about augmenting medical therapy. EP talks about changing device settings to optimize. We look at arrhythmia treatment, and obviously we consider novel device therapies, probably none more so than CCM, because it's a nice place where CCM is a place where EP and heart failure really come together. And then this is a one-time visit, so this isn't a place we follow patients with continuity. We'll then share recs with their general cardiologist or whoever's their main cardiology provider, and then they sort of pick the ball up wherever we leave it. Next slide, please. This has been an amazing experience for us. There's obviously challenges scheduling 2 doctors together. The clinic workflow can be challenging because of all the testing that needs to be done. Oftentimes we hope to have an echo that's very recent prior to the visit, and sometimes we don't get that. And then obviously making sure that we get patients into these slots. CRT patients have a habit of getting lost in our system sometimes after the upgrade, and we don't know how they've responded. We are constantly now expanding the reach of this program. We used to call it a CRT non-responder clinic. Now we call it our combined EP heart failure clinic, because we're taking on complex ventricular and atrial arrhythmia patients and anyone really who sort of benefits from both of our care. Next slide, please. There's obviously successes and challenges. So those were some of the challenges. The successes we've seen is that our leadership in the health system has been very supportive of this program. It's been a regional differentiator. It's led to a lot of ability to publicize a new thing we can offer that other places within the region don't. It's definitely led to more of a lot of different things that are good for patients and good for business. We actually charge 2 copays for each visit, which is why we're able to justify having longer visits. And it's really patient-centered. The patients respond incredibly well. I think they love seeing 2 doctors in the room talking to each other and the patient. I think they feel very well attended to. We've not yet had one patient in a couple of years of existence of the clinic complain or have issues with paying 2 copays. So there's no limit as far as patient buy-in. And our post-visit feedback has been phenomenal for these patients as well. So this is another nice way to bring together 2 different areas of our practice to improve uptake of some of these novel therapies. I'm going to skip over these slides, but you can all review them at your own leisure. This is our single center experience with PA pressure monitoring and a 2-center experience with us and another center here in Kansas City using CCM in the first few years. Suffice it to say, we've seen really promising results with both devices. So I'm going to turn it over to Lisa now, who's going to talk to you about the really important stuff, kind of the nuts and bolts of how we make these programs work.
I'd like to echo Tim's thoughts on the thanking the HA for allowing us to speak. And I'm sort of going to talk about sort of how we put all this in practice. This is my disclosures. So we're going to start off with the pulmonary artery monitoring program. So you have to have a core team. Usually medical director is one of the heart failure cardiologists. Sort of figure out who's going to put these in. Is it going to be an interventionalist? At our facility, our heart failure MDs, we have 3 implanters for this, and then having APPs that do the post-implant management, RNs that you need to either have a lead RN or a program manager with others to do all the monthly billing, the protocol management with our guidance. And then how we're going to bill for this, having that IT, the help with the integrated heart record, and then those device clinical specialists. Next slide. Then how do we get these referrals? I'm not going to go over this very much because Tim talked about this. This is, we have a record BPA that fires in the EHR. So having that set up, doing the chart reviews as Tim talked about, and then getting out to the other physicians, general cardiology, external and internal, and also from our hospitalist team for patients that are being seen by them on the inpatient. If they've had several heart failure admissions, flagging that to us for us to look at. Next slide. The company provides comprehensive tools and resources that can help with implementation of this program and management of this. These includes practice program and coding guides, patient videos, which are phenomenal, that you can actually give to the patient to review while you're there in clinic. That goes through what the device is, what the implants look like, how do they download. They have great patient websites that gives them more information, and also brochures to hand to them that you can use while you do your shared decision making, but also that they can take home and share with their other family members. Next slide. So this is sort of our clinical workflow. So templates are key for this. So everything something doesn't get missed, and everything can be done just exactly no matter which nurse or nurse practitioner is looking at stuff. So pre-implant, this is patient education, what are the expectations, getting the insurance approval, doing a prior auth if we need, getting the right heart cath ordered, and then getting that implant procedure date set, and then following up with CD scheduling to make sure that they have actually got it on the schedule and the patient is aware. The day of implant, we do a right heart cath at the same time, so that way we can correlate the right heart cath numbers to the CardioMEMS, so we calibrate that so they match. They do need to be on antiplatelet therapy for 30 days, so aspirin and usually Plavix, unless they're already on anticoagulation. After 30 days, they're on aspirin alone. Most patients go home the same day. The reps bring in their equipment. They explain to the patient and the family how to use that. They do an actual download while they're there in the bay, and then they go home. Next slide. The next day, our RN gets into the remote monitoring database and they activate that patient. So they put in what is the goal ranges, what is the right heart cath numbers. The physician that does that discharge summary puts the goals in that summary so their nurses know what to add. They set up that text message communication so we know which phone number we're texting to so we can text reminders and letting them know we reviewed their readings between the clinic and the patient. Then that program manager or the lead RN assigns one of the heart failure nurse practitioners that's going to be managing that patient. We have requested that if it's a patient that we don't already manage in clinic, that they set up a one-time clinic follow-up appointment with us so we can get to know the patient. They know us, so they are not realizing they're getting recommendations from someone that they've never met. The only difference is within our program, our LVAD and transplant patients that have these pulmonary artery monitoring devices, there is a heart failure APP that's assigned to do the billing, but the everyday management is done by the heart failure MD and then the VAD and transplant RNs. We didn't initially start out that way, but it ended up being too many cooks in the kitchen. And then the patients didn't know, did they call the transplant office? Did they call us? And it just led to a lot of confusion. So it's worked much better since we made that transition. Then the RN makes a call to the patient at home the first business day after implant. They give the patient instructions on how our program monitoring is done, what is their expectations in regards to communications with us. And then we have a dot phrase that lines this out that we put in our electronic health record. Next slide, please. Can I get the next slide? I'm not going to go over this. This just shows you in the interest of time, this is what that implant information looks like. It has the number, what they're supposed to do. Next slide. It also includes troubleshooting tips, and then that goes into the record. Next slide. The daily process is the patient downloads from home that goes into the remote monitoring protocol. We have now integrated that with our electronic health records, so it also automatically flows over into our result review tab in the chart. The heart failure APPs do the initial management for 3 months. After 3 months, if the patient is stable, then we transition that to our R team, and they have a management triage protocol that they use depending on if their EF is greater or less than 50. We review the data waveforms at least twice weekly, and we send a message to the patient that we have reviewed your waveforms. If it is out of range for more than 2 days, we get an email alert, and then we can go in and see what the problem is and make adjustments. The other reason we have the heart failure APPs doing the management for the 3 months is we're not only looking at diuretics, but we're looking at optimize those vasodilatory GDMT, especially for our HFrEF patients. The RNs have diuretic protocols, as I talked about, depending on if they're HFpEF or HFrEF. This also factors in the variabilities like kidney function and what their current diuretic dosing is. So if the creatinine is more than 2 or they cannot double their diuretics safely, then that gets routed to us and then we make the treatment recommendations. For our patients that are on dialysis, we can collaborate with their management nephrologists. We provide them a monthly report of the readings, and if their readings they're out of range, then we contact that nephrologist in the way that they have asked us to, so they can make adjustments for their volume management with their dialysis. These next 2 slides, these are the triage protocols. I'm not going to go over them for the sake of time, but they are there in case you want to look at them. Next slide. So other things is technology and IT setup. This sort of shows the different things that you have need for that. Secure message routing. So we have a dedicated in-basket team. So they can just put cardiomems, nurses, and then that goes to all our nurses. We also have an email that is set up that includes the APPs, the physicians, and the nurses. We have set remote monitoring notes for pre-post implant and for our daily monthly billing. These just are the common codes that we can use for implant and also our monthly billing and reimbursement. Next slide. These are the tidbits that you need to have in your note in order to get paid. It has to be at least 30 minutes of clinical staff time, and that can be a combination. It doesn't have to be one person. It has to include any review of interventions in the last month. You have a review of the waveform and review of the ratings. And then they create a bill, and then we have to attach an attestation to that bill. The key is the patient has to download once every 4 consecutive weeks, or we cannot bill on them. That's something that had happened about a year ago, and it's sometimes we work for free, unfortunately, for some of our less compliant patients. Next slide, please. So this is just an example of our note template that we have set up that has all those things I just talked about. Next one. So you do have to have the waveforms and all that. We found out afterwards that's something that they do require. Next line. Quality metric. Let me just go back real quick. Once that is done, then the nurses send that to the APP that's assigned. We review all that, and then we have a dot phrase that we attach on there that we have reviewed all this. We agree with the changes. If there's anything I want to add, like maybe their PAD that day is elevated, I may make a recommendation. That is all in that note. Next slide. Quality metrics, as we know, we have to justify the cost and to also expand our program. So these are some of the things you can look at and follow to be able to justify the cost, and also to get the expansion, especially for if you're going to have more of a APP and nurse-led team, to get those positions, because it is nurse heavy. Next slide. We're now going to skip to our BAT patients. So the baroreflex activation therapy. As you can see, the core team is a little smaller. You have the heart failure cardiologist or the champion, your implanting surgeon, whether that's vascular, ENT, or CTS, a program coordinator, and then a heart failure nurse team, and a billing specialist. For the infrastructure, they do have lots of resources that are available that can help you in assisting, setting up your program, and also how we manage these patients. Clinical workflow templates, not only for referrals, but for patient identification, and how we do then the clinical workflow for pre, post, and implant management. Next one. So our referral sources could be heart failure providers from outside of your institution. So having that network of saying, hey, this patient is a little sicker, can't do anything with their drugs, we need to send them to see what maybe they can do. And then general cardiology, sending a referral to be seen by a heart failure provider, internal and external. So this is our referral screening checklist. It hits all the main things that we need to know and what they need to send to us if we're going to see a patient for a referral. Next slide. So pre-implant workflow is this patient initially has a consult with one of the heart failure providers. We do a shared decision making. We talk about what the barostim is, or sorry, the BAT is. And if we feel they are a candidate and they're agreeable to the device implant, then we place a referral to our vascular surgeon. And then they look at them from a surgical standpoint. They'll do their carotid ultrasound, all that, to make sure that they're surgically a candidate. Then we submit for insurance. Once we have approval, then we get them scheduled for their BAT implant. This is sort of how that goes. It's usually done in either a hybrid or operating room suite. This is sort of how that procedure overflow is, how they put it in. Takes about 1 to 2 hours. Most patients will go home the same day, but sometimes if they're having a lot of pain or they're concerned about that wound, they'll stay overnight. In yellow is the most important part. Don't down titrate their GDMT at implant. Even if their blood pressures are like right now, like 88, 90, it's very important that we don't address their drugs at that time. Next slide. This is post-op, so their initial healing phase. We don't really do full device activation until about 2 to 4 weeks post-implant. We want to make sure that wound heals. We don't have any infection issues. So that first post-implant check, we're going to look at their vital signs. We're going to see how they're feeling. We do want to make sure they see the surgeon 4 weeks after implant to look at that wound. We usually see them around the same time. And then we will do like their initial titration visit. Subsequent titrations can be RN-led, so they can come in just for an RN appointment to do that titration, but one of us has to be available in the office at that time in case there's issues. Or if they're seeing a heart failure provider at that time, then we'll just tag that into our clinic versus visits. And then timing of later visits with the heart failure provider really depends on how well the patient is doing. Next slide. So that first activation.
Lisa, could I, sorry, just interrupt just for one moment. For both BAT and CCM, the titration is done by device reps from the companies. So when we say nurse-led or whatever, there is a device rep who's present for all device titrations and all troubleshooting. So the companies are really good about having that just full and complete availability. So it's not as though your team has to learn how to do that on their own. That's all under the purview of the companies that create these devices. Sorry to interrupt.
No, thank you, Tim. I meant to clarify that and did, so thank you for that. So at this first activation visit with the heart failure providers there, so we start that stimulation. We're looking at blood pressure, heart rate in real time. We get them up, we walk them in the hallway, see how their blood pressure and heart rates respond. And then we're seeing, some of them can feel when that stimulation gets started or increased. And so it should settle down. But the one lady that was symptomatic, I had to do half titrations with her because it was too much, and that worked out really well. And we're trying to maximize their autonomic benefit. So then we're seeing them every 2 to 4 weeks, and we're doing those titration until we get them at their optimal functional tolerability and efficiency on there. We're looking at what is their NYHA functional class, what their blood pressure is, heart failure symptoms. And then we typically don't really up titrate GDMT, but I have had to adjust down titrate some diuretics, especially as that autonomic tone starts to improve. Next one, their long-term follow-up. After we get them to optimal therapy, then we're seeing them every 3 to 6 months once they're stable, depending on how they're doing and if we are starting to need to optimize GDMT. We have seen that their vital signs have improved, blood pressure has improved, and it's allowed us to really increase some of their GDMT because they've had that autonomic stabilization. We're also looking at, have they had heart failure hospitalizations, what their 6-minute walk test, what is their quality of life score with that. Every 6 months, they do have to come in to have an impedance and battery check. That can be done in a nurse visit if they're not seeing one of the heart failure providers. Next slide. This is sort of what I developed a dot phrase for our titration notes. So that is what this looks like, and it can be put in a note by itself for that visit. Quality metrics, as we know, this is the ways you can follow this to justify the cost and also to expand on there, especially that heart failure hospitalizations. If we really notice it starts to decrease that, they're always looking for that. Operational, those are things you can look at also. I thought this non-respiter rate was interesting, and that might be something we look at in the future. We haven't really talked about that yet. Next slide. Billing and reimbursement. We are in the process of getting all that finally set up where we can bill for titration visits in the office. And these are the codes that we can use. And then for routine follow-up, if they're coming in to check that device, there's also a billing code that can be input also if you're seeing them in the office at that time. And then our CCM, as you can see, the core team, heart failure ND, but also then the EP, device clinic staff, and then the heart failure nurses. Facilities, you have to obviously have the equipment for device implantation and access to imaging, which is listed to there. And then there is also a comprehensive set of resources, which also will help you set up this program and manage these patients. Next paragraph, or not, next slide. This is the referral, a little bit more narrow referral from outside heart failure providers and then general cardiology. Clinical workflow templates for everything. I tell you, they make life sweet for these type of device workflows. So pre-implant implant is consulting with the heart failure provider to say, are they eligible? So, you know, we have people that refer to us, and then we have to look then at all the baseline, their labs, their EKG, their their meds are, do they need a CRT? If they don't have one, what is their echo? If we feel that they do meet qualifications for CCM, then we send them to our EP colleagues to then meet with them to talk about implant and to make sure that they are a candidate from an implant standpoint. Next slide. If they say they are a candidate, then we get insurance approval. And once we have that, we get them implanted. This is how it goes the day of the workflow. That's actually how they put the device in. Typically, they go home the same day. Rarely did they have to stay overnight. Next slide. Wound care, post-op, you know, just making sure that, because it is open very much like an IC or pacemaker, so making sure that site heals. They do a device interrogation prior to discharge. Then we are seeing them in heart failure or EP clinics, depending on how you have it set up. 1 to 2 weeks post-implant, making a device adjustment if needed. What's the wound like? And then have they been in the hospital? What is their NYHA class? And then we're always looking, can we optimize GDMT? Next slide. Then we see them every 3 months. These are the things that are in that we're looking at that 3-month mark. How have they responded? Do they need a little bit more tweaking, or have they responded really well? Depending on how they've responded, then depends on when do we see them again. So at that 6-month mark, if they're responded pretty well, then we may not see them for another 6 months. So those are all the things that would be looked at each of those visits. Next slide. Long term, once they are stable, if they're responding well, then you're doing an annual device review. They may be seeing us more often in heart failure clinic, but EP would see them once a year looking for arrhythmias, and then also have they been in the hospital, what is their quality of life score and their NYHA functional class. The quality metrics, these are things you can look at to help justify your program costs and expansion. Next slide. This is billing and reimbursement, what you do for the device interrogations, and then for the office visits. And I'm going to leave these slides in here. This is just sort of how you can set up a collaborative referral process in there, sort of how we have set ours up. We only have 5 minutes left. I want to make sure we have chance for questions. So if you do have questions on these slides, if we could go to the very last slide on there, there's my email address. Feel free to reach out to us, and we're happy to get that information. With that, we will be thrilled to take any questions if there are.
Thank you so much, Lisa and Dr. Fendler. And I think as you kind of wrap up with these last few slides, Lisa, the one question that I see we have here is, can you please explain how you're able to find the appropriate patients in your acute settings through the EHR system to meet and establish referrals for your devices?
Do you want me to take that, Tim, or do you want to do it?
Sure, I can talk through that a little bit. I think my understanding of the question is how we find patients from acute. I'm assuming you mean inpatient or ER settings is my guess. So that's the question I'm going to answer. I hope that's the right question. As I showed and Lisa alluded to, we've created a workflow where we have cardiac nurses who keep an ongoing census at all times of any patients admitted with a diagnosis of heart failure to any of our 4 hospitals in our system. And so every single one of those patients after discharge, we get an EHR message into a shared inbox that 5 of our advanced heart failure docs review at all times. And when we review that small amount of information, it's small but mighty, I would say. It gives us really all the pertinent information to understand what options there might be for different patients. It also looks into things like whether they're compliant patients, whether they have challenges with substance abuse, whether they're following up appropriately. So you can kind of look through there and see what's there. And then we make a decision at that point. So this is the workflow we created in the small implementation science study that was industry funded that I showed you the results of for getting more patients with implanted with field pressure monitors who would benefit from them. And we now use this workflow as a catch-all for all of these new areas of heart failure care. So CCM, BAT, referrals to the structural valve program, to the advanced therapies program, any number of things. This has been a really honestly priceless workflow for us, and we're in the process of trying to detail in more explicitly what we have created with this system, which we hope to eventually present at a national meeting sometime later this year and hopefully eventually publish as well. Because this is a workflow that if you have an EHR and you have cardiac nurses who are dedicated and who you trust, you can really allow for, like I said earlier, getting touches on so many more patients that you don't have the time to see on your own. So anybody who's interested in hearing more about this, we specifically have Epic, but I'm sure this could be applicable to any EHR. And I'd be more than happy to talk with people offline about how we set this program up and how it's worked for us.
So it's really building that. I was able to get back to that slide. So you really got to get a best practice alert built to fire in the EHR. So we put it based on their mission diagnosis, elevated biomarkers, heart failure emissions, anything that would fall in that for those device therapies, that it will fire that. Hey, consider this. And then that's sort of then how the nurses also can get that information. So it's really that best practice alert that really can help us catch those patients that we may not see in clinic or may be seen by general cardiology in clinic.
And the only other thing I'd mention, I know there's other questions, but that old phrase about a rising tide and all ships. What we found with this is that we empower our patients, our nurse practitioners, our general cardiology, interventional EP partners. Sometimes we'll bring them in if there's the next person seeing the patient. You can see on the little form that that's one of the things is who's seeing them next. So we'll fold someone into the message group and say, hey, this person's coming. Are you comfortable talking about CCM or any number of these device options? And I think through that pathway, what we've created is a lot more comfortable adoption on their own, where now I have partners who are sending me messages in our EHR saying, hey, I've got this lady. Do you think she'd be a candidate for CCM? And maybe she's not, right? But they're thinking about it now. And that's when you champion a program or you try and build something new at your institution, that's when you've kind of hit this critical mass, when people are starting to ask you instead of you bothering them with, hey, would you think about this for this patient of yours? So that's been a really exciting development. Kelsey, do you want us to tackle these questions we see, or how do you want to?
If you want to go for it, if you can see them, go for it.
Yeah, great question. So I'll just, let's see, I'll start with the first one about insurance denials and who's absorbing the cost. It's a great question. And I have to be honest that it's not necessarily something that we track, the ones that are denied. We do have a pretty robust experience now with going through the appeals process, prior auths, denials, approvals for PA pressure monitors, because anybody who has a program knows that we've all been fighting that battle for the better part of a decade at this point. The national coverage decision has really changed the game on that. But when PA pressure monitors were newer, the companies that make these devices offered services. And now the companies that make CCM and BAT offer similar services that will do a lot of that legwork for you. You can either sign a contract as your health system with the companies, or you can have a pathway where for both of those companies where an individual patient can sign a contract with those companies to advocate on their behalves. And then all of the workload and cost that might be incurred with going through the appeals process or sending PAs, or the time that clinic staff might have to spend doing that, can be offloaded to these companies. Obviously, this is a symbiotic relationship, right? And they have a vested interest in increasing implants. So I don't know that I can tell you much about the cost or what's absorbed, but I will tell you that implanting over 100 PA pressure monitors last year, and the size of benefit that comes to the program because of that, I would tell you that I believe it probably outweighs. Of course, you have to get to that point, so building the program to that size is not so easy. As far as the second question about non-invasive devices replacing these therapies, I think at this time, as far as CCM and BAT, I don't really know that there's a pathway for that. There are certainly a number of companies that are creating non-invasive or implantable PA pressure monitoring or intracardiac or intrapulmonary pressure monitoring devices. We participated in a trial of one last year that's simply a monitor that sits on the chest for 5 minutes and can estimate CVP and wedge. So I think that yes, in the future, there will be a time when these PA pressure monitors are supplanted by non-implantable options. But I don't know that it's so soon that it's not worth building these programs, because they've really been invaluable to us, both in improving our patient experience and improving our reach with patients in and around this area.
Some time to stand for. It looks like we have one more here too.
Yeah.
Wondering, we have someone from an long-term care facility with LVAD residents, and wondering if these patients are candidates for LTC care or nursing homes.
Yeah, great question. I'm assuming you mean these specific novel device therapies we're talking
I think
about.
that's what I think so too.
So yeah, definitely. So the motto I mentioned, set it and forget it, is very true for CCM and BAT. CCM devices, I mentioned briefly, they have a charging that has to happen for 1 hour a week. It can be in the seated position. It's a small charger that plugs into the wall. We have patients hanging over their shoulder right onto their device, whichever side it's on. We tell them to watch TV or read a book for an hour while it charges. Barostim doesn't require any such charging. Both have an internal battery, just like an ICD. So there's generator changes that have to happen through vascular surgery or EP every number of years. But the device being in place doesn't limit where the patient can live or exist or go. The only thing we really have to educate our healthcare staff on is that both devices, which sometimes are on and sometimes are off, will create a certain kind of interference pattern on telemetry. So that's about the only thing we have to let people know. Other than that, there's nothing that limits an LTAC or a SNF taking these patients. It's nothing really different than having a patient with a pacemaker or an ICD, I would say.
Yeah.
Great. And I think that brings us to the end of the questions we have here. So I'd like to thank Dr. Fendler and Lisa for your time today and for sharing your expertise on this subject. For those who are asking, this recording will be available through Zoom webinars. You can reach out to me if you have issues with that. My email is here and in the slide deck that we put in the chat. And it will also be available enduring on our heart failure education website. And I would just like to remind you guys that we have 3 additional events coming up through the rest of the month on Thursdays at noon again. So if you have not had a chance to register for these, I encourage you to do so, and we look forward to seeing you next week. Thanks again, and have a great rest of your day. We're all good. Thank you, guys.
Well, thank you. Happy to do it.
Yeah, thank you. Sorry, I think I was a real motor mouth. I was going really fast. So sorry if it was too fast.